All right. Welcome, everyone. We're going to go ahead and get started. Thank you so much for logging in and for joining us today for the CDIM oral abstract presentations. I'm really excited to hear the conversation from all of our presenters today, both on the work that they've been doing and then also getting a chance for you all to ask your questions. There are two options for doing that. There's both the Q&A option and a chat option. So if you do have questions as our presenters are going through their abstracts, then please feel free to put those in. We'll try to get some of the questions answered from our presenters directly. However, it is also possible that we have to move on to the next person, in which case keep an eye on the Q&A and the chat, as those presenters will be able to answer those as the next person is talking. So with that, I want to move directly into our first presenter, and that is Dr. Jennifer Pascoe, who's at the University of Rochester. She's going to be talking to us about the use of metafeedback to improve the quality of narrative evaluations of trainees. Dr. Pascoe, please take it away.
All right, thank you. Okay, so today I'm going to be telling you about a study that I did with my colleague and co-investigator, Dr. Amy Blatt. We're both at University of Rochester. So the first thing you're probably asking yourself is, what is metafeedback? Because you've probably never heard of it, because we essentially made up that name. So metafeedback is basically feedback about feedback, or evaluation of evaluations. So this is a faculty development technique that we utilized, and it does one-on-one individualized coaching and feedback. And I hope that after you hear this, you might be interested in employing it yourself. All right, so just for a little bit of background, at our institution, there's a pretty strict clerkship grade distribution. And within the medicine clerkship, clinical performance counts for 70% of the grade. We have a grading committee, and each individual member looks at all of the faculty and resident evaluations of students to stratify and quantify their clinical performance. We did have some anchored rating scales, which changed over the years. But despite these changes and the addition of caveats and descriptors of how to utilize the scale, we still saw that scores were remaining really clustered at the high end of the rating scales. So because of that, we ended up obviously heavily relying on the narrative comments to distinguish the students. But as you can probably imagine, the narratives were not always of the highest quality. So what we were realizing was that all of our traditional faculty development workshops that we had been giving hadn't really seemed to improve the narrative quality of the evaluations. So our hypothesis was that faculty members simply may not even know what elements comprise a high quality narrative evaluation, and that they may overestimate the quality of their own evaluations, kind of like a Lake Wobegon effect. And based on conversations that we had had about other faculty development, we realized that people wanted some more individualized coaching and development as faculty members. So this spurred our study, and we basically combined quantitative and qualitative metafeedback to see if we could improve the quality of narratives that were written. So eligibility for our study was any hospitalist at our main teaching hospital who had attended on a teaching team. There were 32 eligible and 22 enrolled, and they were randomized into 2 equal groups, control and intervention. Now, before I tell you a little bit more about our methods, I want to tell you about the Narrative Evaluation Quality Instrument, or NEQI. Now, this is a previously published tool, and it basically allows you to assign a score from 0 to 12 to rate the quality of a narrative evaluation. So this score is based on the number of performance domains that were commented on, things like clinical reasoning or fund of knowledge or professionalism. It also adds in the use of qualifiers, evidence, and examples, and then grades the overall usefulness to the trainee. So our general methods before the main intervention, we sent a survey to both groups, and we also randomly selected 5 narrative evaluations that had previously been written by the 22 faculty members. Those were de-identified, and then both Dr. Blatt and myself scored them using the NEQI and created some personalized reports that I'll tell you about in a moment. So the actual intervention, the 11 faculty members in the intervention group received a copy of those 5 de-identified narratives that they had written. They got a personalized PDF that explained their NEQI scores, interpreted them, and gave examples. And then the real meat of the intervention was this 20 to 30 minute one-on-one feedback session with one of us, where we sat down with them and reviewed their narrative evaluation quality and gave them feedback on how they were doing. And the control group did not receive anything. So this is very small, but this is an example of the PDF that they received. There was one of these that went with each of their narrative evaluations. So here's just a little snippet of what you might see from the larger one. This little snippet shows the supporting evidence. So part of it, as highlighted here, is checkboxes and a little bit of boilerplate information. And then what we also included was examples from the narrative that they had done to show why that was good or not good and gave tips. Part 2 of the meta feedback was that one-on-one meeting. And we started the meeting mostly talking about the NECI scores and reviewing the evaluations that they had written. And since this was a little bit more of an objective measure of the quality, it was a good entree into the meeting. It kind of set the stage with this objective data that we could let them know where they stood against their peers. And then the conversation really became free form after that. And it varied depending on the faculty member. So sometimes we talked about, maybe somebody had lack of constructive feedback, or they weren't phrasing their constructive feedback very well, or maybe they were using language or adjectives that were inappropriate, such as commenting on personality. So we really kind of just went in different directions. And this free form part of the conversation, we were able to talk about things that weren't directly reflected in the NECI score, but are still important to having a high quality evaluation. So after these meetings were done, we let some time pass until people had written more evaluations. And we again selected 5 random ones for each person in both groups, de-identified them and rescored them. There was also a post survey as well. So here's the pre-post survey results. 2 main questions were, how confident are you in knowing the key components of a high quality narrative? And how confident are you in your ability to write one? So you'll see that the control group really didn't change much from pre to post. But the intervention group improved 2.6 and 2 points on a 5-point Likert scale, respectively, for both confidence in knowledge and confidence in ability. So there was a pretty big change there. Now, the NECI scores themselves. If you look on the left, you'll see at baseline, our control group and intervention group started with pretty similar quality of evaluations based on the NECI score. But by the end of the study, there was a significant change in the intervention group. And this was statistically significant. Here's the actual numbers. So highlighted in red, you'll see the intervention group started with a 6.71 score on a scale of 0 to 12 and improved to an 8.03 at the end of the study. And in the 3 columns, there are the subscores, which also all individually improved. This looks a little complicated, but here are the 11 faculty members in the intervention group showing their mean pre and post scores. So if you look at the ones with the arrows, those are the 5 faculty members who had the biggest change from pre to post. So if you look at number 3 and number 9, those are faculty members who started out pretty low. They had fairly poor quality evaluations, and they rose quite a bit, as you might expect, because they had a lot of room to grow. But if I draw your attention to faculty member number 5, this person actually started out with very high quality evaluations, somewhere around a 9, greater than 9, and was still able to improve quite a bit with this intervention. So in conclusion, we found that the quality of narrative evaluations as measured by the NECI score did improve following our meta feedback intervention. We had free response survey questions, which really showed that faculty enjoyed this individualized coaching model and receiving that personalized feedback. They mentioned that they had never received anything like this before and were really grateful for the opportunity. So after this experience, we really believe that peer-to-peer coaching like this fosters a collegial, growth-oriented culture for faculty, which we think is very important. Now, in terms of time, scoring using the NECI takes about 2 minutes once you know how to do it, and compiling the PDF report takes about 20 minutes. Then you add in the meeting, so it's about an hour per faculty member. So I know this does take some amount of time, so one potential thing would be to target limited faculty members, such as those who start out with poor quality evaluations, or maybe new teaching faculty who are new to your division. And I just want to say thank you to my co-investigator and our mentors and our study coordinators. So I will stop there. And if we have any questions, I'm happy to answer.
Great, thank you so much. And I'm not seeing questions so far. Just a reminder for everyone that you can use both the Q&A function and the chat function to be able to ask questions of our presenters. Dr. Pascoe, you kind of got into this a little bit for at the end, which was my big question was about sustainability. My thought of being a clerkship director and having to do this across my 4 sites seem daunting. And so I'm curious, you addressed a little bit with, targeting certain faculty, but then I also worry about certain faculty being left out. Is this something that you would see continuing to go on, or is this something that you could rotate to different faculty so that after you got your new faculty, for instance, you could then target some other faculty in the next year to try and eventually get to everyone?
Yeah, I think there's a few ways to go about it, and we could certainly train other people to do something similar. What we're planning to do is for example, we're introducing a new site. So we're going to be doing this with those new faculty members who have never written student evaluations before. And then most likely with the new teaching hospitalists who are, again, new to the service. And I think as the years go on, we're going to try to slowly pull in other people, but that's to be determined.
Okay. And then Dr. Snood has what I think is a great question, which is, she's curious if there are demographic differences on the part of the faculty within each group.
Yes, there were, and I did not include that slide. I want to say male and female was pretty equal. I think there was a slight skewing on I might be mixing it up here. One was a little bit more experienced in terms of years of experience, and I don't want to misspeak. It was a voluntary enrollment, so we did think that there was possibility that we were self-selecting for people who were, most open to improvement. So it'll be interesting to see how this goes with people who are doing it when we are not voluntarily asking them to do it.
Great. All right, to keep us on time, why don't we move to our next presentation? So our next presentation, we have Dr. Nakaktar, who is going to be talking to us about watching what they do, strategies for implementing a hybrid EPA assessments in inpatient clerkship. And this is work that he has done out at the University of Minnesota.
All right. Hey, yeah, so we are going to be talking about our institution's experience with implementing a hybrid EPA assessment. So a little bit of background for you. So EPAs are becoming increasingly used as medical education in general moves more towards competency-based education and evaluations. EPAs tend to be integrated into existing frameworks rather than throwing out the old framework and using EPAs instead. And so when you integrate and implement them, there are some challenges that tend to come up. So for example, you have to work with or around some of the established practices. There may be some varied understanding in your assessors and what the EPAs mean and how to assess them. EPAs are meant to get to a certain level of entrustability, which can be difficult to do in a fixed time curriculum because you need to make some decisions about entrustability after a fixed amount of time. And it can also be difficult if you leave the EPA assessments open to ensure that the students are being assessed on the EPAs that you actually desire. So our institution has had a lot of experience with EPAs and LICs, and particularly the EPAC project in PEDS, if you're familiar with that. And so the goal was to try to apply this to using EPAs in core clerkships. So here's a little bit about how our institution did it. So institutionally, what we did is we used EPAs on all 7 of our core clerkships. We took some of the more common scales and really used the Chen scale in particular and simplified it, which I'll show you in a moment. And the other important thing is that it was student initiated. So students were taught about the EPAs, how to obtain them, and they were the ones empowered to actually seek them out. And so what the student would do is they would pull up their mobile device like this, and hand it to their assessor, who is an attending resident. And then that assessor would choose the EPA from that list, and then it would take them to the scale that we use, and then they provided their feedback on that. Each of our major clinical sites also had site-specific experts to help with the faculty development and to answer questions about that. And all of this was monitored centrally. So the clerkships and the students got reports every 1 to 2 weeks on how they were doing. On the internal medicine clerkship, we made some additional changes. So we actually required EPAs 1, 2, 3, 5, and 6, and I don't expect anyone to be that familiar with them. So I'll kind of go through and explain what those are in a bit, but these are the ones that are felt to be typical for a core medicine clerkship. We required that students receive 4 EPAs per week, which were reviewed at mid-clerkship as a way of providing some formative feedback and ensuring that students were doing okay with this. We did put some limits on who completes the EPAs and how often to ensure that students were getting a good range of them throughout the course of the clerkship rather than relying on 1 or 2 people at just 1 or 2 time points in their clerkship. And we also provided some guidance documents, and I'm showing you an example here, so that any assessor who needed some guidance in the when they first started on the wards and anytime that they needed it could refer to this as a method of how to do it. Looking at some of the results, there are 4 questions that we're looking at here. The first question we had is how often are specific EPAs completed? So the medicine clerkship sort of took a different approach. The other core clerkships really only required EPAs 1 and 2. So if you look at the stars, the maroon stars are what medicine requires and the gold stars are what the other clerkships required. So 1 is history and physical and 2 is differential diagnosis. For internal medicine, we also included interpretation of labs, note writing, and presentations because we felt those are pretty typical for internal medicine. And what you'll see is that a lot of the EPAs 1 through 6 were pretty routinely obtained in internal medicine, and most of them. Internal medicine did not get a bunch in 7 through 13, but really I think also important to this is that EPAs 5 and 6, so that's the note writing and oral presentations, were pretty heavily represented, and that gets into this idea of the existing framework. So a lot of our assessments really relied on oral presentations as a surrogate for some of the other skills and on note writing because reviewing a student's note is required for billing. And so even as we tried to push towards using the other EPAs, they did still have an outsized effect on how much they contributed to student assessment. The second question was how many EPAs can students receive per week? And that's one of the things we really wondered is what is a reasonable expectation for how many students should get? So the internal medicine clerkship, again, you'll see in maroon here, required just 4 per week throughout the year. The other clerkships here in the gold required 2 for 4 months and then move it up to 4. And, you know, there's a more variability in the first 2 blocks of the other clerkships because they required fewer, but everyone tended to gravitate towards 4. So the idea is that students can pretty reliably get around 1 per day that they're on a clerkship without a whole lot of effort. Third question we had is how entrustable can students be at the in their 3rd year clerkships? And part of this is we have our clinical competency committees looking at the student evaluations, and the big question there is how entrustable should we have a student be if we say that they're meeting their expectations for their clerkship? And so looking at the clerkships, and really what we were looking at here is that rating of 4, which on our scale is that rating of indirect supervision, and students pretty reliably, especially in the core ones, even EPAs 1 through 9 tended to get pretty close to 4. So as we're thinking about what does a student need at the end of 3rd year or even to graduate, it looks like indirect supervision is probably within reach for most students. And then one of the other big unintended consequences that we thought about is how do EPA comments differ from the summary comments? So traditionally, our faculty would sit down and write summary comments on their own computer on their own time, but here with the EPAs are being done while their student is right there. And so those comments on the EPAs, and these are all from the same person on the same student, but at different points in time. The EPA comments tended to be very brief and focused on very specific instances and behaviors, whereas the summary comment tended to be more general and did more summarizing with sort of the intent of explaining how the student might be for a candidate for residency. And so a few points of discussion about this. The core clerkships EPA 1 through 6 were routinely measured whether or not we or other clerkships required them. They tended to get them, but the current frameworks still rely pretty heavily on EPAs 5 and 6. So we do need to do more work to really try to push getting the other EPAs that we want. 7 through 13 were not routinely obtained on a core clerkship, and they may be more suitable for acting internships. So Dr. Garber is actually going to talk about that in a moment. The idea that we can get students probably to indirect supervision as a target is likely achievable for most students. And the idea that you need to have a lead-in period in terms of frequency in integrating the EPAs is probably unnecessary as people just sort of gravitated towards the final number no matter what. in terms of points for our assessors, their comments tend to be focused and brief, which can pose a problem when we're thinking about content summaries for letters, such as a standardized evaluation letter in MSPE. So either more training on the folks who are writing the evaluations or folks who are providing summaries will probably be important to ensure that the students are reasonably getting information for the residency candidacy. Prospective EPAs were also tough for a lot of folks because a lot of prospective EPAs, for example, entering orders, a student cannot do that independently. So even though we said, hey, you should think about if a student might be able to, if they, if the rules weren't as they were, evaluators still tended to cap them as they always require supervision. And that's really something that needs to happen in targeted training. External monitoring and point of contact guides were critical, even though we provided a bunch of upfront information and faculty development, they still needed that constant source of information and guidance throughout the year. And the EPAs did have a lot of redundancies with our currently existing frameworks. And so as we integrate them, the assessors didn't like seeing the same thing captured on both. So we're actually removing them from our traditional evaluations and just including them on the EPAs. So I will stop for questions. And I see that there are a couple. By the way, this is the QR code for the poster. If you didn't grab it, you can grab it now. Yeah, so Chris, I don't know if you want me to get into these now, if you want me to talk about.
By all means, I think no, I think we have some time. If you want to, I'm curious to hear your answers.
Sure. So in terms of the list of the procedures under 12, so the procedures actually tended to still weigh heavily on procedures themselves, and so as opposed to general behaviors of the physician. So, for example, strictly speaking, patient counseling is something we consider a procedure, but that didn't get captured in that. So we actually have a supplemental evaluation that picks that up. That's probably one of the reasons why internal medicine didn't have a lot, because what sort of fit in under the AAMC rubric of procedures tended to just not come up a lot on our core clerkship. So the competency committee is comprised of so each one is being led by one of the site experts that I mentioned earlier, and then the rest of the people on it are attending faculty, and they meet every 2 months, and each person has a group of 6 to 8 students, and they follow them longitudinally, so it's not clerkship specific. So I'm on one of them. I have 7 students, and I just monitor their progress and provide feedback on them throughout the year. And that's something we're sort of figuring out as well. Yep, you're welcome. And then how do we arrive at the decision to have the students hand their phones to their faculty? The idea behind this was to really make it student driven and student empowered, so that the students had some control over how getting these done. And some of this is just really logistically. It's a lot easier to train up the students and say, hey, we want you to get this information, get this feedback, and we want to make sure that these conversations happen. And so we put it in the hands of the students rather than just kind of hoping that the faculty and the residents would do it. And what's really been interesting about that is that students have actually done really well with that. We actually are moving more of our student assessments to be student driven, just because the students have been so good about making sure that happens and gets done. So.
Great. And on that, I just hopefully have one quick question for you on that, which is every time I think about a technology solution, I worry, I know there are no attending physicians that would be laggards in that respect, but have you had any issues with attendings that are uncomfortable sort of using the student's phone or interacting with the interface?
Great question. And actually related to that is, even if the attending is not technology phobic, if there's COVID and people don't want to touch other people's phones, or they're busy and they say, I'm trying to eat my lunch or something. And so we've actually allowed the students to act as scribes. And so the students can actually say, if you don't want to enter it, tell me what to put in. I will put it in. And one of the great things about our system is it then generates an email to the assessor. So the assessor can see, yep, the student did scribe this correctly. And if there's an issue, they can actually reach out. But having student scribing has actually been probably about half of the time how it occurs.
That's awesome. Thank you so much. And as you beautifully alluded to in your presentation, I think we can take this opportunity to move from the clerkship into the acting internship. So next we have Dr. Adam Garber, who's at Virginia Commonwealth University, and he will be talking to us about incorporating core EPA-based curricula and workplace-based assessments into the acting internship. Dr. Garber, take it away.
Right, let me get this up and running here. So yeah, this is, if you guys can see my screen okay. So this is a great segue from Dr. Nakaktar's presentation. So I'll be talking about incorporating the core EPAs into the acting internship along with these workplace-based assessments. All right, so despite the movement in undergraduate medical education towards competency-based education, as well as core EPAs, I think we can all agree there remains large gaps in skill development, as well as competencies within new interns. So the challenges arise not only when ascertaining the proper time and place to implement the core EPA curriculum, but also the assessments in the curriculum. And that's in order to focus on competency attainment and also degree of supervision needed within fourth-year medical school, as well as the acting internship rotation. So this is in part due to lack of best practices, as well as objective clinical performance data, especially surrounding the core EPAs and the acting internship, which can aid in monitoring student skill development and progression, as well as serving as a needs assessment to the actual curriculum. So our orientation day curriculum, we developed as a school-wide AI curriculum, and it also integrated workplace-based assessments during the acting internship after the orientation session. So our core curriculum, as you can see, focuses on the following EPAs. We trained the students in iPass for patient handoffs, which is what our institution uses. We also taught them how to do a consult, which we labeled as EPA 6 and 9, which is patient presentations and interprofessional collaboration. Tips to cross coverage, which we lumped under EPA 10, which is the sick patient and attempting management. Order entry, obtaining informed consent. Then we did some basic electrolyte repletions and insulin dosing, which is they're things that the students need on day one of the acting internship. All right, so for the workplace-based assessments, students are required to complete 2 AI rotations at our institution for graduation, and they're required to request the same workplace-based assessments for both AI rotations. These activities can be observed by residents, fellows, or attendings, but not interns. Students must request these workplace-based assessments during their AI rotations, but completion of these workplace-based assessments by the supervising physician cannot be enforced since this is out of the student's control. The data is collected in our learning management system, which does have some limitations as we don't have an app, which would be nice to help increase our completion numbers. And then all of our workplace-based assessments include an Ottawa supervisory scale, which is used as a gauge of their ability to perform these activities and the level of supervision needed consistent with the aims of the core EPA pilot. And these workplace-based assessments are designed to ensure students are provided the opportunity to perform these tasks during the AI rotation, and in addition to gathering the student clinical performance outcome data. All right, so this is a nice visual of the workplace-based assessments we require during the rotation, which is laid out by week. So as you can see, we require 4 patient handoffs throughout the rotation, so 1 a week. For the consults, orders, and informed consents, we have a pair of those throughout the rotation. So hopefully they perform or get 1 workplace-based assessment of these in the first 2 weeks and then another in the second 2 weeks. That way we can monitor their progression. And we emphasize with the students that these are not used for their grades. So hopefully they're more proactively getting these done and aren't waiting till the very end to request all these when they're actually probably much better than they were at the beginning of the rotation. As you can see across the bottom, the EPA 10, which is a recognizing sick patient and attempting management. So there are 9 conditions. So that's a lot of workplace-based assessments. So we tell the students to try to complete 4 to 5 of these per AI. So hopefully by the end of both AI rotations, they'll have hit one of these conditions in entirety. So if one AI, they have trouble getting these, one AI rotation, especially outside of medicine, they may have trouble. They can at least hopefully get a few of these observed, and on their subsequent AI, they can try to get the remainder of these, especially if it's in the emergency department or the critical care environment. All right, so on to results. So this is the aggregate number of Ottawa supervisory rating by core EPA. So you can see we had over 9,500 workplace-based assessments over 2 academic years, and over 3,100 workplace-based assessments actually completed. So this, unfortunately, still corresponds with a completion rate of 33%, which I'd like to be higher, but it is in line with our clerkship completion rate as well. So of note, the lowest completion rates of the workplace-based assessments requested was in EPA 10, as I mentioned, recognizing sick patient, and EPA 11, which is informed consent. Now, EPA 10, I think the completion rates were lower because of just the situation they may be in and asking the provider to fill this out. But also there's so many conditions that likely they didn't get a number of those completed over the course of the 2 AIs. And then informed consents, those often are challenging to get in certain AI rotations, say psychiatry, for example. So they have to try to make these up on the subsequent AI, which has been a challenge for some students. But as you can see, the majority of performance data show that the students are reaching the Ottawa supervisory scale of a 4, which is I need to be available just in case, highlighted in yellow, and blue, which is level 5, I did not need to be there. So those are the target performance levels we'd like them to hit in preparation for intern year. So it's good to see kind of across the chart there that the majority of the students are hitting those marks by the end of their AI. And I'd also like to highlight, as you can see, the highest numbers of 4 or 5 are in EPA 8 or patient handoffs. All right, so this is the same data, but shown as a percentage of the Ottawa supervisory rating scale by EPA. So as you can see, kind of down the line there in the blue and yellow, across the board, about 80% or more of students are hitting that 4 or 5 mark on the EPAs at some point during their acting internship. And this is across the 2 academic years combined. So now breaking this down by academic year, this is particularly important because the graduating class of 2021 was one of the first classes affected by the COVID pandemic and altered clinical experience. So they likely had less clinical experience to begin with. And then at our institution, they were only required to complete 1 AI rotation instead of the traditional 2. So they had less opportunity to practice and perform these skills. So as you can see across the bottom, the total numbers didn't significantly change. There was a slight decrease in the target scores within EPA 6 and 9, which is the consults, EPA 10, recognizing sick patient. But as you can see, there was an increase actually in patient handoffs performance for that graduating class of 2021. Now, despite this, there wasn't a significant change in target scores across all EPAs, as I mentioned. And I'd like to highlight once again the highest combined target scores were in patient handoffs, so 88% hitting that target 4 or 5 supervisory scale. All right, so in conclusion, our workplace-based assessment data provides objective evidence that students can reach that target performance level desired of the core EPA pilot during their acting internship. And this corresponds with the performance level desired of a new intern. Additionally, it became apparent that these workplace-based assessments also helped change the culture of some of the AI rotations outside of internal medicine that previously had not allowed or provided opportunity for these students to perform these clinical activities. So in turn, it strengthened some of these other AI rotations and allowed students to more consistently perform these clinical activities. As I mentioned, despite the altered clinical experiences secondary to COVID-19 pandemic, there was no significant change in performance across the EPAs for the graduating class of 2021. Our handoff curriculum was successful and allowed students to develop and hone these clinical skills, which is typically an area of deficiency for new interns. Now, challenges remain with ongoing low workplace-based assessment completion rates, as I had mentioned, which is likely multifactorial, but as I mentioned, also it's a level consistent with our clerkship, so on par with their performance as well. And this does not limit our ability, this does limit our ability to perform longitudinal and individualized performance analysis, just given the numbers completed. But overall, this data does support the effectiveness of our AI curriculum and also shows that the 4th year students are capable of performing these core EPAs at the target performance level desired for intern year. And that is it.
Great. So Dr. Garber, there's a couple of questions. I don't know if you can see them in the Q&A or not.
So how do we select which AIs to focus on during the AI? So it kind of built off what the clerkships weren't covering. And also, you know, the acting internship is often kind of the last opportunity for students to perform some of these EPAs, especially the more advanced EPAs. So if we aren't addressing them during the acting internship, they may not get an opportunity to practice these at all prior to intern year. So there was some planning between going over the clerkship list as to which ones they were tackling, but we already had in mind for the ones that we wanted to tackle as well. So I hope that answers that question. And from Jen, the performance-based assessments provided as part of the student's grade are more formative feedback. So they're not factored into the grade whatsoever. So at this point, it's formative feedback, and the students actually have a EPA coach they meet with throughout third and fourth year. So they actually do review some of this data as well and kind of see how they're moving on their trajectory of reaching that target performance for intern year. So that's, I think, a benefit. Otherwise, I think there could be some selection on the students as to when and who they request these observations from. So students so far, we haven't had many students that are not hitting the mark. Some of them are not up to par necessarily in their first week or so, but do reach that target performance level near the end. We could do, as our learning management system changes, which it will, I think, in the next year, hopefully we can monitor this a little more closely. As you can imagine, it does take a lot of manpower between our administrative support and then how many students we have. We have about 160 to 170 per class. It's quite a lot to keep track of, but it would be nice to hit these even during their AI or potentially between the two AIs, so you could have them work on specific things they aren't doing well for their second AI. Let's see, for the next one, how is EPA 10 assessed? So recognition or initiating approach. So the way we phrased the workplace-based assessment was, did they recognize the urgency of the situation? And did they seem to take the appropriate diagnostic steps to figure out, what was going on with the patient? So they couldn't go in there and spend 10 minutes getting the history if it was a very urgent situation. So that's kind of how we ask how they recognize the situation. And then we also ask how was their management of the situation as well. So it did ask both. Say challenging questions. Yeah, and oftentimes it depends on the clinical situation. So it's hard if the patient's really not doing well, that let the student sort of run the show. But if you both go in there together, the student, we encourage them to say, hey, can you let me try to take care of the patient by myself, and you can chime in or take over if I'm struggling, if I need that help. For students that rotate with us in medicine AI, we kind of know when we can let students go see patients by themselves for urgent pages versus not. But we try our best to give the students as much autonomy while having the patient's best interest in mind as well. All right. I don't know if Chris, I have time for this one from
Yeah,
Urs.
I think you
Okay.
can.
So any thoughts moving towards competency-based language evaluation, given students coached and assessed over a couple years? So, I think some of this, ultimately, we would love to have kind of like what they have over at Minnesota with some of these competency committees. I think that's the ultimate goal, and have this all align. It's just, how does this factor into grades, graduation, remediation even, right? And having time for students to come back and potentially do additional time if they need on certain AIs or certain rotations. So I think that is the ultimate goal, and certainly something I think we need to work towards. But how that incorporates, especially high stakes decisions like that, with are they ready to graduate with these metrics? We've got to get our completion rates higher, first of all, and hopefully add some validity to this before making that high stakes decision on that data.
Great. All right, Dr. Garber, thank you so much. And now we're going to shift topics just a touch, and we're going to move to Ms. Fadoju, who is at The Ohio State University. She's a medical student there and is going to talk to us about the impact of race-based medical misinformation education on medical student perceptions of racial healthcare disparities. So Adam, if you want to stop sharing your screen. Thank you.
Hello, my name is Deborah Fadoju. My pronouns are she, her, hers. I'm a third-year medical student at the Ohio State University College of Medicine, and today I'll be presenting the impact of race-based medical misinformation education on medical student perception of racial healthcare disparities. The authors have no financial interests or relationships to disclose. Background. Racial disparities have long existed in healthcare and remain uncorrected. At the institutional level, many physicians never learn about the historical manipulation of science and medicine to justify racist beliefs and practices. At the individual level, implicit bias amongst providers contributes significantly to healthcare disparities. Notable efforts centered in physician training, such as Harvard's implicit association test, aim to address this issue. But are these efforts enough? We argue no, because a focus on physicians alone ignores medical students, critical members of the medical community. Historically, medical education has focused on the treatment of medical ailments with little emphasis on how social determinants of health influence health outcomes. We felt this void deeply after finishing our first year of medical school and being disheartened by the lessons that weren't taught. We also believe that while implicit bias training is vitally important, alone it is far too low a standard to hold medical providers to. Opponents may argue, on the contrary, student doctor, evidence shows that implicit bias training results in increasing diversity in medical school admissions. I fully recognize this and celebrate those efforts, but after over 2 decades of diversity and equity training efforts, and although we have in fact diversified our medical school classes, racial minorities remain grossly underrepresented among faculty in academic medicine, and long-standing healthcare inequities have yet to be adequately remedied. Which tells me this, that the solutions we've raised to address healthcare inequities have yet to reach their intended goal. We realized that ensuring that medical students become physicians who are committed to uprooting the negative effects of racism would require radical reform of our medical curriculum's portrayal of race and racism with strategic ingraining of anti-racism teaching. So we created a module and case-based discussion that did just that. Description of the intervention. So this is our study timeline. Between March and April of 2021, first-year medical students were given a pre-survey to assess 3 things. 1, their knowledge of racial healthcare disparities, both general and lecture-based. 2, their awareness of racial medical mistruths. And 3, their comfort level discussing the topic of race. Here are some sample questions included in the survey. We've also provided a QR code to view all of the survey items. The pre-survey was followed by our lecture, Race-Based Medical Misinformation, History's Impact on Today's Medical Practices, in which we discussed the historical origins of medical mistruths, such as Black people have lower lung capacities than white people, and connect them to present-day impacts, such as the use of race correction in spirometers, which can lead to inaccurate estimates of disease severity. The lecture was then followed by case-based discussions. Here's an example from the case-based discussion. In each of the cases, we highlighted the medical mistruths from the lecture, such as Black people have higher pain tolerance than white people. And some of the discussion points were, how are patients viewed in a sickle cell crisis? What implicit biases held by providers led to the patient's outcome? Identify time points in this case where the patient's healthcare providers might have responded differently to these concerns. How might these alternate responses have changed the patient's outcome? This discussion was then followed by a post-survey. Outcomes. General student knowledge was assessed using a 5-point Likert scale. Statistically significant pre- and post-survey differences were observed in 2 general knowledge-based items. The first item, there is a genetic marker for race, had a pre-test score of 1.98 and a post-test score of 1.54. The second item, Black people are less likely than white people to adhere to recommended treatment regimens, had a pre-test score of 2.66 and a post-test score of 1.98. These findings suggest improved medical student knowledge about race following our teaching module. The knowledge gained by students from our lecture was evaluated using true and false questions. A statistically significant difference was also noted between the aggregated pre and post survey averages, 94% versus 97%. Of the items listed, 2 in particular stood out. The first, agreement with the statement that Black infant mortality is higher now compared to white infant mortality than it was in 1850, had a correct response increase from 77% to 93%. The second, agreement with the statement that race correction factors are used to incorporate race into care, with white being the standard, had a correct response increase from 73% to 88%. Although modest, these results indicate that students were successfully able to retain knowledge that was introduced through our lecture and clinical exercise. This figure shows the results of the survey questions that assess general student attitudes regarding race. There were no statistically significant differences between the pre and post survey. Similarly, survey questions that assessed general student comfort regarding race showed no statistically significant differences on any items between the pre and post survey. This highlights how ingrained attitudes and comfort regarding certain topics will not shift simply from one intervention. We must therefore incorporate more of these discussions throughout medical school to see a real shift in future physicians. In conclusion, this educational intervention proved effective in increasing knowledge regarding medical mistruths. However, student comfort discussing the topic of race and their attitudes towards race-related constructs remained unchanged, likely due to the fact that established beliefs more frequently shift when people receive significant exposure to different environments, cultures, and ideologies. This intervention's success was dependent on buy-in from institutional leadership and students' willingness to engage in sensitive discussions. But for substantive change to be seen, institution-led escalation of these efforts are necessary. Medical schools must create environments that normalize exploring and discussing the impact of internalized, interpersonal, and institutional racism in medicine. So what now? Our lecture has now been integrated into the first year curriculum at The Ohio State University College of Medicine. And in 2022, we had the second iteration of this intervention. We're going to continue to evaluate the impact of the lecture and the cases and compare survey responses to the data from previous cohorts. Our institution has also adopted an anti-racism action plan, which aims to re-examine all medical school lectures and integrate social determinants of health throughout the curriculum, as well as incorporate training courses that educate students, faculty, and staff on the topic of race in medicine. Here's some of the feedback we received from students at the conclusion of our intervention. We asked students to rate the quality of the intervention on a scale of 1 to 5. The 2021 cohort had a total of 98 responses with an overall rating of a 4.29 out of 5. This year, there were 138 responses with an average rating of 4.71 out of 5. This shows that our approach was largely well received and that students did have a thirst for this information. Numerous students commented that this was the best lecture they had during their M1 year. Others thought that the content was eye-opening and were shocked to not have heard this information discussed. And yet more, we're thankful that we took the time to craft and present this data-driven material on race-based medical misinformation. Still, there were a group of students who found that the material we presented was too extreme, too far-fetched, and too focused on the impact that race and racism have on the outcomes of Black patients. These comments highlight how shifting established beliefs is not always easy and often requires more frequent exposure to the content. When we asked students for ways that we could improve this intervention for future iteration, there was a resounding ask for more time, more cases, more discussions. We are currently working to incorporate this feedback to ensure that these small group sessions are as impactful as possible. We recognize that our single intervention is simply a start, not a solution, and that this topic needs to be longitudinally addressed throughout medical school for there to be real, sustainable, tangible change in the attitudes of future physicians in regards to racism in medicine. However, our experience has shown us that when given the opportunity and the resources, medical students are responsive to curricular reform and are, in fact, eager to learn more about the topic of race and racism in medicine. With that, I'd like to thank you and thank all of my co-conspirators.
Excellent. Thank you so much for that presentation. It seems that from your conclusions, you do have some sort of vision in mind of how to get students more of this content. Do you have a vision for what this would look like across 4 years of medical school?
Absolutely. One of the feedback that we constantly get as students is that they believe that this should be physician-led, and that physicians should take over and that students should be students and just teach. But I'm of the belief that there's a particular buy-in from peer-to-peer led interactions. And there's also a particular level of comfortability that comes with talking with your peers and being open and honest about what you know and what you don't know. So my hope with this is that this continues to be, at this level, a student-led intervention that partners with the institutional-led motive for change.
Great. And I'm not, I'm not seeing any questions popping up yet. So I can, nope, never mind. Wondering about any similar intervention for faculty and residents. It seems like a wonderful intervention.
That's a really good question. I'm not aware of particularly interventions going on the residency level, but I'm sure at other institutions they're doing it.
Sounds like your next project then.
Probably.
All right.
I do see a question. Rosine asks, thank you, Rosine. I appreciate that. How can other medical students at other institutions do similar work? What inspired you to do this? I'll start with the last part of the question, what inspired me to do this? In the summer of my first year, after I finished an entire curriculum, that's kind of when the world shut down at the height of both the global pandemic, but then also this rising awareness of racial injustice and this rising move to address healthcare inequities in a meaningful way. I knew that I didn't want the momentum of that movement, of that moment, to be just a moment. I wanted something to happen that would be long-lasting change. So the idea kind of came about to create a curriculum. And luckily, I had overwhelming support from peers, from faculty, from deans. So that's kind of what inspired this. And then in terms of how can other medical students at other institutions do similar work, I very, very passionately believe in medical student advocacy and believing that as the future stewards of the healthcare system, that we need to be as integrated and as invested in advocating for change in whatever system that we're a part of. So the time to start for medical students will never be tomorrow, it'll always be today.
Thanks. So I'm just going to keep signing you up for stuff. Is there any, if there's not, is there any avenues that you have for getting other medical students at other institutions together on this project? Because I would love to see your stuff replicated at other institutions.
I would absolutely love to do that. I've had the opportunity, me and my coworkers, to present this information at another university called the University of Toledo College of Medicine. And it was very, very well received there. But I would really, really like the opportunity to share this and encourage other medical students to begin to do the work in their own institutions as well.
Great. All right. Well, not seeing any other questions at this point, I think why don't we wrap up a little bit early? And since all of us are very connected to all of our students, I think that all of us could maybe make an effort to connect. Miss, I'm going to try to not butcher your name because you corrected me on the pronunciation. Fadoju. Yes, all right, good. So maybe we can connect you with some folks and just keep putting more things on your plate so that you can solve this problem for us. And with that, I'd like to thank all of our presenters. I'd like to thank Dr. Pasco, Dr. Tar and Dr. Garber, as well as Ms. Fedoju, for taking the time out of very busy days to talk about all of the excellent work that they're doing. And I'd like to thank all of you for coming and participating. And it's been great to connect again. And I hope that you all have a good rest of the day.